Okay, good morning everyone. So I'm the lead clinical scientist in the 3D imaging lab at Sheffield Teaching Hospitals, which is part of the Department of Medical Imaging and Medical Physics. So I'm going to give a brief introduction of our 3D lab, how it was set up and why we set it up. I'll give a couple of examples of the type of processing that we're doing routinely, and then move on to the developments that we've been exploring with Mimics over the past year that we've had the software available. So just a brief introduction of Sheffield Teaching Hospitals. So it comprises of 5 adult hospitals in Sheffield, and they comprise of over 2,000 beds and 16,000 staff. So it's one of the largest teaching hospitals in the UK. So why do we need to do 3D imaging, and why is it useful to have a 3D lab? The current requirements for 3D imaging are ever increasing, and typically MR and CT studies contain hundreds, if not thousands, and sometimes tens of thousands of slices in a case. So the traditional methods of interpretation of looking at every slice individually are just becoming less and less appropriate. So we need to transform this data somehow to make it more readily, such as a volume rendered data set. So it's much easier to interpret the anatomy from this volume rendering. Other reasons why we might want to do image processing are due to limitations in visual perception. Now actually the human visual system is very good at pattern recognition, and you hopefully can see the Dalmatian dog in this image. So although it contains very little information in this image, your brain is able to interpret it and identify the dog. And this is a similar process to the interpretation of medical images, and what radiologists are trained to do is identify subtle abnormalities such as this one in this chest x-ray. So we're very good at pattern recognition, but what we're not very good at is making sort of quantitative assessments of images. And this very, very simple example, it's obvious to see that the block at the top is half the volume of the lower block. But when you move to a slightly different, or slightly more complicated geometry, okay, you can say the upper sphere is smaller than the lower one, but it'd be difficult to say that it's twice the volume or half the volume. And when you move to a real-life example, such as a brain tumour, then the sort of visual interpretation of an image to say, yes, I think this tumour is growing, is very difficult, and the only way to properly assess that is to make a measurement. And the brain can also be easily tricked. So if I was to ask you which of these two squares, square A or square B, was darker, show of hands, who thinks A is darker? So the majority think A is darker. Well, actually, if I move square B onto A, and it's exactly the same grayscale intensity. So your brain is being tricked into thinking it's different. And we have the same issues when interpreting colour. So it's a slightly weird colour on this display, but basically we've got yellow and magenta swirls interlaced by, honestly on this screen it's blue and green. Can you see the so you see the sort of bluish swirl there, and there's a green swirl there. Well, actually if I move part of the blue onto the green, it is actually the same colour as the green. On this screen it is. And so it's not inconceivable that similar illusions can happen in medical images when you're trying to interpret them by eye. So can we do some form of image processing to improve the interpretation? And in this simple example, if we set all the yellow and magenta pixels to black, then they become the same colour. And I'll show you on the screen later, it's more impressive. Honest. So that's the sort of idea behind the 3D imaging lab, is we want to apply these sort of techniques to medical images to maximise the available clinical useful information from the images. And this should lead to increased diagnostic confidence, improved therapies, surgical planning, improved communication not only between radiologists but with the referring clinicians, but also the patients themselves, if they can understand what's wrong with them better. And wherever possible, we want to extract quantitative information from the images so that we can reduce the subjective nature of the interpretation. So when we set up the 3D lab, which was back in 2010, I was lucky enough to go and visit 3 labs in the USA, which are very well established. They've been going for probably 20 years now. But the common approach to all of these labs is a centralized, protocol-driven type of processing, where the processing is being done by 3D lab technologists, or radiographers in our case in the UK. And we brought back those ideas to the UK, and the advantages of doing it in a 3D lab are we get much improved standardization and consistency and reproducibility of our results. And because these people are using the software all the time, we get much higher operator expertise, which leads to improved quality and efficiencies. And we can also target the results to the application. So what do I mean by that? Well, in the very simplest case, we can reformat our axial data set in the coronal and sagittal planes. You don't need a 3D lab to do that. Most software will do it for you. But then moving on, we can then view the data in an oblique plane, which may be more appropriate for the type of pathology that we're trying to look at. And if that feature that we're trying to identify is curved, then maybe a curved plane reformat is more appropriate, such as trying to measure the diameter of a vessel by automatically extracting the center line along the vessel. Then all the cross-sectional views are perpendicular to the axis, and so we can measure true diameters of the vessel. And we can create a straightened view of it and then measure the profile of the diameter of the vessel more accurately. Moving on, rather than just considering a single slice, if we actually consider a block of data, then what we can generate is what's called a maximum intensity projection, where we extract the maximum pixel intensity in that block along a line of projection. And this is really useful for vascular imaging, where basically, it accentuates voxels with high intensity, such as vessels containing contrast. And this is used extensively in vascular radiology and neuroradiology. We can also combine a MIP with an NPR view, so we can view that at any oblique plane. Another technique is minimum intensity projection, which is effectively the opposite of maximum, where we're extracting voxels with low intensity values, such as tissues containing air. And then moving a sort of stage of sophistication further, in volume rendering, each voxel is assigned a particular color and transparency. And these colors are defined by various different transfer functions. But what it means is some of the voxels become completely transparent, which means you can then visualize deeper structures. And this is used extensively in radiology now. It didn't used to be in the past. But what tends to happen in most radiology departments is a cine, such as this, is sent to PACS for the referring clinician to view. But that's all they can do with it. They can play and stop that movie. They can't interact with it in any other way. And for surgical applications, it's important that the surgeon can fully interact with the images to get a true understanding of the anatomy. So the only ways to address that are to either give the surgeons access to the software, the volume rendering software, which can be quite expensive, and it's not always the easiest software to use, or can we manipulate the data and produce a surface rendering, such as this. Spinning around a bit fast. So from the training courses yesterday, you obviously realised that this takes a considerable amount of time to do the segmentation. But we feel that the advantages that this type of image give us far outweigh the time penalty of actually producing it in our 3D lab. So by effectively removing all the tissues and information that isn't required from the interpretation, such as removing the bone or the other vessels, and setting parts of the model to be transparent, then it can drastically improve the interpretation of the images. And if we can distribute this to the surgeons as a 3D PDF, then it gives them that full flexibility of the interpretation. And the data is already in a format which can then be readily passed on to other systems, such as a virtual reality system. And we've been working with the University of Sheffield to perform a virtual colonoscopy, a true virtual colonoscopy, where we can effectively fly over the colon, but then also fly through it and walk through it with a headset on. And it's as though you're immersed in a colon, which is a fascinating but somewhat disturbing procedure, but I'd highly recommend it if you get a chance. And the data is also in a format ready for 3D printing, which I'm not going to dwell on because the rest of the talks today are going to cover that in a lot more detail than I can. So which technique is best? Well, it depends on these various different features here, and we tailor what results we produce based on these sort of criteria. So just give very quickly a couple of examples of the type of processing that we're doing. So this is a volume rendering example for catheter ablation for atrial fibrillation, and we're producing a volume rendered image of the left atrium and pulmonary veins. So we do a subtraction of the image, and it gives us this volume rendered image here. But this contains other structures which we're not interested in, such as the aorta and the pulmonary arteries. So by doing image segmentation, we can remove those and then give a nice 3D volume rendered image of the anatomy. Another example is the assessment of the growth of a low-grade glioma. So we're looking for an acceleration in the growth because this is a good indicator that the tumour is transforming and becoming malignant. And these patients are monitored every 3 to 6 months. And traditional ways of assessing the size was to do a two-dimensional measurement such as that. But that immediately raises questions, well, which slice do we measure? That's highly subjective. It's a highly irregular shape, so a two-dimensional measurement is probably meaningless. And we also get problems between follow-up scans with differences in patient positioning. So in this example, there's a slightly different caudal tilt in the head position, which means when you come on to do your measurements, you try and find an appropriate similar slice to do your measurement on. But if you look at the posterior part of the brain, then you're clearly in a different area, and you're not measuring like with like. And the only way to get around that is to do a true volume analysis, which is what we do. And the software that we've got allows us to do this in about 5 to 10 minutes. And then from that, we can then produce a graphical representation of the growth and identify these areas of acceleration in the growth. And the downward curve is post-therapy in this case. So now I'd like to move on to the applications that we've been using Mimics for over the past year. And we've been exploring a whole range of different specialties. And I'm going to give you a quick run through of some of these. So the first one is in cardiology. And we've been using the Mimics software to segment the heart for catheter ablation for ventricular tachycardia. So in this procedure, a special catheter is inserted into the heart, and it's used to localize and then treat areas which are potentially giving these life-threatening arrhythmias. But in order to do that procedure, it's useful for the cardiologist to know the anatomy, and also bits of the anatomy which aren't sort of usually given from a simple segmentation, such as the wall thickness and the thickness of the epicardial fat and other structures. So from the segmentation from Mimics, we can produce a model such as this, which is showing the epicardial fat in yellow, and we've got a colour-coded map of the wall thickness of the left ventricle. And we've also developed some software to convert the STL from Mimics into a format that they can then load into their mapping system. So they've got the anatomical model fused to the model they generate during the procedure. And this gives them greater confidence as to where they're doing the ablation, but they can also target the ablation more appropriately to the areas which are more likely to have the issues. We've been able to combine multiple modalities as well, so not just CT. In this case, we've got nuclear medicine myocardial perfusion imaging registered to the CT. And from that, we can then produce a model where, again, this is going a bit fast, when it's just in the yellow and blue phase there, that's the myocardial perfusion scan. And we can see that we get good correlation between the the myocardial effusion scan and the wall thickness, which is what you kind of expect. We've done a similar thing with cardiac CT and cardiac MR, where we've fused the CT and the MR together, and we've identified regions from the delayed gadolinium enhancement scan. And from that, again, we produce another model where we add in the scar tissue. It looks a bit blocky on here because the MR scan is quite thick slices. But nevertheless, that information is really, really useful for the cardiologist. Moving on to ENT, this example, the surgeon needs to bury this device into the mastoid bone. It's a bone conduction device for patients with middle ear problems, and the sound waves are transmitted directly to the inner ear. But the question is the mastoid big enough to accommodate this device, which is about 15 millimeters in diameter and about 10 millimeters deep. So that's where it's positioned, so you can just see it behind the ear there. So what we've done is we've done the segmentation again in mimics of the bone and soft tissue, and then exported that information into MATLAB and developed some code to do a thickness analysis, but not just the thickness of the bone. What we've tried to do is simulate the position of the transducer in all those positions within that area that we've done the analysis on. So the green areas are where we think the device will fit, and blue areas where it won't fit. And just as an example, this is a failed position. So I've represented the device as a series of vectors. And then if you do a cross-sectional view, you can just see it poking through. So put the device on, you can see it just poking through into the sigmoid sinus. So obviously you don't want to put it there to go right through the skull. So if we move the device slightly to the anterior position, this was a past position where it didn't go through, and so that's an acceptable place to put the device. And so we produce this as a 3D PDF, and the surgeon can then plan with more confidence that the device is going to fit. Into general surgery for planning of perianal fistula. This is an MR data set of a fistula, and it's notoriously difficult to interpret. It's difficult for the radiologists and almost impossible for the surgeons to work out what's going on these images. Now the radiologist produces a very, very detailed report and uses a clock notation to describe the path of the fistula. But I mean, just reading through that, it's impossible to generate a mental picture of what is happening and how am I going to treat this patient. So the question we want to do then is, can we produce a pictorial representation effectively of the report? And we've actually done the segmentation in different software to mimics because we need to have multiple images open at the same time to do the planning. So it'd be nice if the mimic software had that capability where we can import multiple data sets at the same time. But from this we generate masks, and then they're then loaded into mimics and 3matics. And we add a clock to the model so that they can correlate our pictures with the radiological report. And this is then what we pass to the surgeon. They don't usually spin it this quick. But we've also added a number of buttons on the side of the PDF so that the surgeon can more easily control the visualization straight from the screen. And those are sort of some of the comments that we're getting back. So the surgeons absolutely love this. Maxillofacial surgery. The surgeons here wanted to assess the impact of some surgery that had performed the insertion of a patient-specific implant for an orbital fracture. And they wanted to measure what was the shift in the eye position pre and post surgery. So we did the segmentation in mimics, and we fitted a sphere to the globe of the eye and then measured the distance to the centre of that relative to these reference planes, and then produce a PDF which the surgeon can then manipulate to whatever view they want. It gives them full control. And there we go. Interventional radiology example. Here the surgeon needs to deliver a catheter to ablate, or not ablate, sorry, to embolize a metastases, which we've segmented from the MR. So they need to get into this hepatic artery, but in the angio suite, when they've got the images, it can be very difficult to say, well, which vessel is it, and how far down that vessel do I need to go, so I'm only treating the metastases and not normal tissue surrounding it. So is it that path? Is it that path? It can be very, very difficult. What we are able to do in the angio suite is collect a cone beam CT image, and then from that produce a MIP, which, okay, it looks like the pre-surgical model that we generated. But what we can do from the cone beam CT is segment that, fuse it or register it to the pre-planning CT, and then give the radiologist more confidence that yes, they're in the right place. The challenge here is the cone beam CT images are awful, difficult to segment, and also we need to do this whilst the patient is on the table, and we've managed to get this process down to about 15 minutes, which we think is acceptable. And just lastly, complex hindfoot reconstructive surgery. We've done segmentation, and we're actually segmenting various bones, or each individual bone separately, so that the surgeon can then individually remove bones, so they can get a good understanding of the anatomy of each bone and the relationships between each of them. And there's an example of some of the models that we produce, and we've also combined MRA data to the CT, so we can get an idea of the vasculature. So just to conclude, the visualization offers many advantages and is a brilliant way of communicating this to non-imaging experts. Surface model is a very convenient way of doing this, but requires accurate segmentation. And that's where we feel having a 3D imaging lab based in radiology is an excellent way of achieving this. Offers methods of extracting quantitative information from the images which are not possible from the images alone unless you produce a segmented model from it. And mimics, we feel, is making this process an efficient and a clinically viable tool. And I think we've demonstrated that with the liver example that I've just shown. And it's a very easy step to progress from these surface models to 3D printing, obviously. So that's the end of my talk, so happy to take any questions if we've got time.